Good afternoon out there, everyone. Dr. Tony Brown coming to you with another edition of Clinical Pearls and Profits. All right, guys. So last week we left off doing some blood tests, and I mentioned that I would do a little bit more stronger correlation between clinical indications and reasons to do a particular blood lab. Now, what I want you guys to think about for today's session is diabetes type 2 and coronary heart disease. Diabetes type 2 and coronary heart disease. What I want to do is give you some unexpected, if not new, information on other markers, other biomarkers that you might track with your patient, that patient that you are trying to convince the reasons that they need to have a more exhaustive blood panel analysis. So we'll talk about a couple today. One will be C-reactive protein. We'll also cover GGT, and we may get time to move into AST. So let's start with C-reactive protein. Now, most of you know C-reactive protein as a kind of generalized all-around marker of inflammation. Okay, so with inflammation, let's talk about a couple of things, how the body sees inflammation. The body, when it sees inflammation, expects that there's infection. Okay, it kind of starts to equilibrate both of those. So much so that there is a type of anemia called anemia of chronic disease, also called anemia of chronic inflammation. And in both of these, they're really the same thing. So in this type of anemia, what happens is the body, sensing inflammation, for instance, via increased C-reactive protein, is afraid that there is either a viral or a bacterial load, an infection that's coming. And so the body knows that bacteria, for instance, love to munch on iron. So the body will take this iron, it will hide it in the bone marrow, inside of macrophages there, and throw away the key. Now, great, the body has successfully sequestered the iron away from the bugs, but unfortunately, it's also sequestered the iron away from the body. And so what you end up with is iron deficiency anemia, secondary to anemia of chronic inflammation. Now, C-reactive proteins is one of the things that is responsible for sending that particular signal. Let's look a little more into it. Reference ranges from none to 4.9 milligrams per liter. So when you look at your lab report, remember that yes, we're talking about C-reactive protein. Yes, it is synthesized in the liver. However, it can be a marker of so many other things. Okay, let me give you an example. Your liver is responsible for manufacturing the proteins in your body. Okay, so therefore, levels of C-reactive protein can be used as a surrogate for liver damage. In other words, but this only goes one way, right? Because I just told you that it's okay to have 0 as a number. Okay, So if you have a damaged liver that's not making any C-reactive protein, this isn't very specific for that or sensitive to that. The call that this is sensitive to is if you have anything over 0 for your C-reactive protein, then evidently your liver must be working. Okay, and then of course it'll be other tests, GGT, ALT, AST, we'll talk about those. There will be other tests that are a little bit more specific as to what might be going on in the GI tract. And as we said earlier, that the C-reactive protein is in response to macrophages' release of messengers. I didn't talk about what messenger that was, IL-6. IL-6 opens up another door, right? And let's say that you have patients who are weight trainers or runners or anything where excessive inflammation might not be a good thing for whatever their hobby or habit or profession is. One of the ways you can measure inflammation is interleukin 6. To me, this is pretty cool. Why? Because what we're really saying is if you have pain and pain is caused by inflammation, that is to say, pushing, the swelling of mass tissue being pushed up against a nerve, trapping that nerve in between the bone and itself, causing pain, then IL-6 can be a surrogate of pain. Right? Those little charts that we ask our patients to do, the little smiley faces, the 10 smiley faces. Here's something you can use as a measurement of pain. The military uses it already to gauge how much pain a recruit might be in. Recruit comes in the beginning of service. They get a baseline of their IL-6 and then take IL-6 based on whatever kind of injury they might suffer. What's the IL-6 after a 5-mile run? So that way, when time comes for battle and the recruit is complaining of pain, they can make an informed decision on when to pull them out of battle. I can see this being extrapolated to sports, professional sports, right? So just getting to you that IL-6, inflammation, pain, surrogates. Turns out C-reactive protein is also released by fat cells. And with regard to fat cells, guys, one good way to look at fat cells is these things, fat cells, can become an organ of their own. I mean, the fat cells can start to pump out not just inflammatory signals, but they can put out all kinds of stuff. You already know they put out aromatase, right? Which helps makes estrogen, converts testosterone to estrogen. Fat cells can have what they call depot receptors. If you have patients on antidepressants, it turns out that antidepressants are stored in fat cells. This is a big deal because if you have a patient who is obese taking antidepressants and then decides to lose weight quickly, what happens is the antidepressant that's been stored in the fat cells all of a sudden gets dumped into the bloodstream all at one time when they're losing this weight quickly. And then you end up having psychotropic events, all because they're just trying to lose weight. Right? So don't undermine fat. It's not just the stuff nobody wants to see or talk about. It's got a lot of jobs. So back to C-reactive protein. The release of this interleukin 6 not only triggers CRP synthesis, but also fibrinogen by the liver. Fibrinogen, as you guys know, is going to be one of the latter products of the coagulation cascade for stopping bleeding, right? For hemostasis. So let's think about that. If C-reactive protein goes up. The body says there's inflammation. One of the things the body does is start to kick off its ability to make blood clots. We just made a correlation between being prothrombotic and pain, or prothrombotic and inflammation, or prothrombotic and high levels of CRP. Now, keep in mind, don't treat these numbers like magic. There are many other labs, and we'll go through them all, that you should use in conjunction with making these diagnoses, right? What I'm trying to give you is a sense of when your patient walks in the door with a certain problem, what are some labs that you can look at and be very sensitive to all of these labs being raised? Not just saying to yourself, well, if my patient has um, cardiac disease, should I only be looking at my cholesterol? Right? No, you're going to get labs today that are even more sensitive for heart disease than cholesterol. In that way, as you're scanning down the sheet, you have a better sense of how not to just scan over some labs that might be slightly elevated, but you say to yourself, I don't really know what that means, so I'm going to keep going, right? We all have done that. CRP participates in the clearance of necrotic and apoptotic cells by binding to phosphocholine expressed on the surface of such cells, thus activating the complement system for phagocytosis. Something even more, right? We're basically saying that when you have dead cells laying around the body, CRP is the signal to bring out all the janitors to clean them up. And it also, with apoptotic cells, fancy word for programmed death, CRP is involved in regulating, that is, clearing the dead cells that were allowed to die through apoptosis. Let's think about that backwards. When your patient has raised CRP levels, what you can expect is things are dying. You may not even know why yet, but what you can expect is there are apoptotic processes going on. And this gives you your first hint to start chasing different things, different differential diagnoses. We'll talk later about how to actually generate a list of those diagnoses. Many substances react with CRP, such as DNA, nucleotides, lipids. There we go, heart disease, we were just talking about it. Excuse me, polysaccharide. So CRP is produced in a wide range of acute and chronic inflammatory conditions like bacterial, viral, fungal infections. We've talked about those. But additionally, rheumatic and other inflammatory diseases, malignancy, tissue injury, or necrosis. And sometimes we kind of limit its power to talking about tissue injury, necrosis, and maybe even malignancy. You can look for, if you can find increased CRP and increased calcium in the same patient, yeah, you really want to start generating a differential diagnosis that list that includes malignancy on there. So I love these numbers, right? Higher levels of CRP indicate a bacterial infection. So we're talking between 40 and 200. Lower levels of CRP between 10 and 40 then you're talking about viral. Higher levels bacteria, lower levels viral. How useful is that, guys? Right? To help generate a differential diagnosis list and then move on from there. You say to yourself, step one, I've got high levels of CRP. I know I'm looking for something bacterial. Let me go through my patient's file and see if maybe they were recently on an antibiotic. If they were, now you keep going, right? And one thing connects to another, and before you know it, they think you are brilliant. Not that you're not brilliant anyway. Decreased levels. Decreased levels of CRP can be found in hypothyroidism, hypothalamic malfunction, and other low levels of magnesium. So the thyroid it's you guys' bread and butter, right? And so how many of you are using CRP to track these possibly low hypothyroid patients? And then, of course, as you know, there's a connection between um, hypothalamic actions and hypothyroid, right? The hypothalamus is responsible for putting out um, thyrotropin releasing hormone. And then it tells the anterior pituitary to release thyroid stimulating hormone. And then the anterior pituitary tells the thyroid to release thyroid hormone. So low levels of C-reactive protein can give you some idea of a malfunction along that entire axis. Hypothalamic action, hypopituitary, not listed here, and hypothyroid. Elevated levels CRP, liver disease, we've talked about it, alcoholism, for instance, alcoholic fatty liver. And we'll talk about in a moment how to look for the relationship of certain labs. For instance, hey, I've got an increased GGT and an increased AST. Where's my problem coming from? With regard to is it in the common bile duct? Is it in the liver? Is it farther down? Okay, we'll give a few examples of that in a moment. Cholangitis, drug abuse, and in some cases, excessive magnesium ingestion. All right. Okay, let's talk about the controversy. Those with a high CRP due to genetic variation had no increased risk of cardiovascular disease compared to those with normal. I know that sounds like nothing, but it really does work itself into your generation of differential diagnoses. So we talked about fibrinogen, okay, the most abundant coagulation factor, which forms a fibrin clot. You guys remember extrinsic, intrinsic. Coagulation comes down to meet the common pathway, and the common pathway eventually forms a clot at the bottom. This is an important measurement of the blood clotting coagulation system. High levels are often seen in increased risk of coronary heart disease, stroke, and myocardial infarct. In other words, high CRP predicts high coagulation factor activity, predicts high risk of coronary heart disease. Levels above 2.4 have been associated with a doubled risk of coronary event compared to 1 milligram per liter. How sensitive is that?